Good. Thanks, Anna.
No worries.
Righto. So we're going to go through the bits and pieces of elbow luxation today, and feel free to raise any questions as you wish. So I thought I'll start with going through some of the elbow anatomy. A lot of us would know these, but it's important for us to just kind of have a basic understanding of how all the bones fit together. So elbow anatomy, it's quite a complex joint to start off with. It actually has 3 bones, and the 3 joints are obviously the articulation between the humerus. Do I have a pointer here, Anna, or not? Can I get a pointer? I can't hear you. Anyway, I'll continue. So the articulation between the humerus and the ulna, and the humerus and the radius, and then also between the proximal radius and the ulna, there is an articulation as well. Traditionally, we thought that the radius was actually the main weight-bearing bone, but biomechanical studies have actually found that in the elbow, between the radius and the ulna, there is actually about a half-half distribution of weight. So the ulna articulates with the humerus, and that takes about 50% of the weight through that elbow joint, and then the radius also takes about that other half. Distally, as we know, the radius actually takes most or all of the weight through the carpal joint, and it's the ligament that sits between the radius and ulna. So if you look on here, it's the interosseous ligament that sits between the radius and the ulna that distribute the weight from the ulna to the radius. So normal range of motion, it goes around 130 degrees. So at flexion, it's about 35 degrees. And on extension, what's important for us to know is that we don't get a full extension. The extension is about 165 degrees. And the reason why we don't get a full extension is because the Ankenil's process, which I'll go through in a few slides later, actually gets hooked into this olecranon fossa, and that's what stops that full extension. A bit more anatomy, which is actually the most important anatomy with regards to elbow luxation. So both medial and laterally, we have a collateral ligament, and both medial and lateral collateral ligaments originate from the medial and lateral epicondyle. And then both medial and lateral, the collateral actually goes into two bands. So each of them, one band goes to the radius, one band goes to the ulna. And then also within the elbow, there is something called the annular ligament. So that's the ligament that goes over the proximal radius. And what the annular ligament does is that it stops the radius from luxating cranially. And it runs, as you can see on the image on the top right, you can see that it runs underneath the collateral ligament. But what's interesting with this ligament is that it doesn't actually attach onto the radius. And because it doesn't attach to the radius, it allows the rotation of the radius with respect to the ulna. And so that motion allows that supination and pronation, as we know. The stabilizer. So what really stabilizes the elbow? And this is kind of important for us to understand when we actually start seeing cases coming through the door with elbow luxation. So the stabilizers, there are actually a few stabilizers in the elbow, and they differ somewhat whether the elbow is in extension or inflection. So when the elbow is in extension, there's obviously the true motion of the elbow joint mainly. So the supination and the pronation. So a good way for us to remember is when we supinate, it's like holding a bowl of soup. So that's supinate, and then pronate is that way. And so during extension, when the elbow is pronating, the anchineals process actually articulates with, if I can get it there, with the supratrochlear foramen in that. So it actually locks onto that hole and actually stabilizes that elbow. And that becomes important later on when we use that stabilizer to maintain that elbow to be stable after reduction. And then supination, so when we actually rotate that antebrachium externally, the main stabilizer is the lateral collateral ligament. So if you think about how your elbow, if you look at your elbow and you supinate that antebrachium, it actually puts, if you can think that it puts tension on that outside, the lateral side, and it's the lateral collateral ligament that really provide that stability during that supination. It's a little bit different when the elbow is in flexion. So in flexion, we no longer have that bony anchor point stabilizing that elbow. So everything comes down to the soft tissue. So when the elbow is in flexion, it really comes down to the medial collateral and the lateral collateral ligaments that's going to provide the pronation and the supination stability, or external or internal rotational stability. As I said, in the flexion, 90 degrees, the medial and the lateral collateral are the primary stabilizer of the elbow. And one of the tests that we employ to in our physio exam to actually work out whether there is instability of our elbow due to collateral ligament injury is something called Campbell's test. And so the Campbell's test, and you should always do this test when you see a dog with elbow luxation. So after replacement, after reduction of the luxation, what you do is, rather than having it extended, you flex the elbow to 90 degrees. And when the elbow is at 90 degrees, you again supinate and pronate that antebrachium. And with excessive supination or pronation, that tells us whether the medial or lateral collateral ligaments are ruptured or stretched. And that tells us whether there's inherent instability in that elbow, whether the elbow may need surgical stabilization. Does that make sense? Nod? Good. All right. So historically, if you look on the literature here, so there's a few older literature that suggests the collateral ligament has are damaged in probably up to about 50% of the clinical cases after elbow luxation. But this 2007 paper actually looked at whether the lateral collateral or medial collateral ligament needs to be damaged before the elbow can be luxated. And so in this paper, what they found is, so they had these elbows in flexion, and they either cut the medial or the lateral collateral ligament and see whether you can luxate the elbow with or without transection of these ligaments. And what Mike Farrow, this investigator, found was that in dogs, in order for an elbow to be luxated, the lateral collateral ligament has to be transected, has to be gone. interestingly, when he did it in cats, so down here you can see that in cats, he found that in order for the elbow to be luxated, both the medial and the lateral collateral ligaments has to be transected. And so in cats, often what I find is that when you reduce the elbows, often they actually feel much more unstable. And the reason I think is because in order for the cats to have the luxated elbow, there probably is quite a significant more amount of soft tissue injury associated probably with the collateral ligaments. I think what's important for us to understand is that a lot of our traumatic elbow luxation is probably due to elongation of those ligaments, collateral ligaments, rather than actually full disruption or full tear of those ligaments. On the topic of cats, very, very much less likely to see it in cats and dogs. I think I see elbow luxation much more frequently in dogs and cats, and there are a few reasons why. So the diagram on the bottom here, you can see that the back of the elbow, there is a ligament called the olecranon ligament. And so that goes from the humeral condyle down to the olecranon. And in cats, that ligament is wider and shorter. And so in order for a cat to luxate that elbow, that really thick ligament has to be ruptured. So I think that's probably the reason why we don't see luxation in elbows in cats as frequent as dogs. I think this slide goes through what I've gone through in terms of the stabilizers of the elbow. And in this slide, you can again see that in pronation, supination, the NA, which is the anchoring process, provides a significant amount of stability in pronation, that dark gray area, whereas during supination, external kind of rotation of the antebrachium, the lateral collateral supplies the main stabilizer. All right, down to the actual clinical side of elbow luxation. So with elbow luxation, the majority, so probably about 90-95% of the elbow luxation we see are lateral. To be honest, I don't think I've ever seen an isolated medial luxation of the elbow, unless I see it with a bicondylar, kind of that Y fracture of the humeral condyle, where you get luxation as well. But I think I've never seen a medial. Most all of the cases I've seen are lateral, and that's a pretty good reason for it. On the medial side, the humeral condyle, the trochlear, is much higher, and there is a slight slope. So the slope actually goes up from medial to lateral, and so that's part of the reason why, as the elbow is loaded, that force kind of goes more to the lateral condyle, and it slips out through that lateral condyle, and then to the lateral direction. And so much more likely to see it in lateral luxation. I think we all know how to diagnose this. Usually with palpation, you can feel that over the lateral elbow, there's a bit of a funny anatomy you can feel, and then radiographs, obviously, I think most of the luxation are quite obvious. In all of my cases, I attempt close reduction first. And I think the close reduction or surgical reduction is really reserved, in my opinion, for the really unstable cases. So in terms of how do you do a close reduction? So like I said, the ulna is often on sitting lateral, so there's a lateral luxation. In order for you to get that elbow back in place, the main thing for you to do is This is obviously under general anesthetic. You flex the elbow, okay, as you can see on that picture. You flex the elbow. What that does is allow that anchoneal process, to disengage from the back of the elbow. So that is not going to get in the way for you. And then what you want to do is you want to internally rotate that antebrachium. And what that does is it allows that anchoneal process to hook into that fossa there, or that foramen. And once you've got that anchoneal process hooked in, then you extend the elbow, and that allows that anchoneal process to hook in whilst you're pushing laterally and hoping that the ulna goes back into that humerus. So that diagram shows it quite well. So flex, rotate, so internally rotate that antebrachium, get that anchoneal process into this hole, and then extend to try to hook it back in place and force that ulna back into the humerus. Does that make sense? Good. Like I said, open reduction, the decision of whether we need to do an open reduction, I always make after I do a close reduction. So I do a close reduction and then I decide, is this elbow really unstable? And I think the cases with really unstable elbow luxation, the ones that have quite severely elongated collateral ligaments or ruptured collateral ligaments. And the ones that I think need open reductions are the ones that you reduce, and then as you reduce it, you move it through a range of motion. And then as you move it through a range of motion, it tends to just pop out or luxate on its own. And I think those cases are the ones that have severe soft tissue damage and are probably good candidates for open reduction plus augmentation. And so often with an open reduction, we approach it with a quadrilateral approach, and then you can use a periosteal elevator to kind of lever that joint back in place. And then once you get the reduction back in place, the decision is, how do you stabilize that joint? How do you stabilize that elbow? And there are a few ways that you can go about doing it. Traditionally, surgeons would repair the ruptured ligament. So that's an option. I'll go through in a sec as to why I rarely do that. The other option is to do a synthetic ligamental repair. So if you look down on the picture, second from the top, you can actually see that there's synthetic suture that you can use as artificial ligaments with bone anchors that you can screw into the bone. And the third option is to use something that you can see on the bottom picture, where you actually put suture through 3 bone tunnels. So one through the humerus and then one through the radius and ulna. And then as you tie those, you essentially reconstruct the medial and lateral collateral ligaments, both sides. So like I said, 3 bone tunnels, one go through the humerus, one go through the radius, and one go through the ulna, and then you tie, and that recreates both strands on ligaments. In terms of, if you were to do a primary repair of the collateral ligament, based on this very old paper, 94 paper, what they found was that so if you actually look at the desmotomy of the medial collateral ligament, so what they did was they cut the medial collateral ligament and then they sutured it and actually loaded it in a vise and actually see how much percentage of the original strength it retains. And what they found was that with the surgically with a fresh transection of the ligament and then upgrade it. Hang on. What's that? Can you see that, Anna?
Yeah.
How come I?
Yeah.
Oh yeah, good. Thank you. So what they did was they did a fresh transection of the collateral ligament, and then they artificially, and then they put a suture to primarily repair that ligament. And what they found was that it only retained 19% of its original stiffness. And so what that really means is that even if you repair a freshly cut ligament, there's not actually much strength that you can repair with a primary repair. And so if you were to do a primary repair, it's advised that you do some sort of external coaptation to help stabilize it. I think with a lot of this traumatic luxation, a lot of the ligaments are probably torn apart, and if you try to repair this ligament surgically, I think it's probably even less than the 19% that this paper reports. It's probably even less. So based on this, I tend not to go with this option of primary repair of the ligament. So my other options, I can't go to, there you go. So my other options I usually go to would be ligamental repair with either a bone anchor or those transosseous tunnels. So back to what I said in terms of if you were to do an external coaptation for an elbow luxation, so this is used for close reduction and what you do after close reduction, or after you do a primary repair and you want to provide additional stability. And this is the splints that I always use when I do a close reduction. And the idea behind a spiker splint is that you maintain that elbow on extension. And so you can, as you can see on the diagram here, it's a splint that goes on the lateral side of the radius ulna as well as the humerus, and then it goes over the actual shoulder blades. And what that does is it maintains the elbow straight. If you try to just do a Robert Jones across the elbow and stops at kind of that axillary region, often you don't get enough stability to maintain extension. So this is what I would make sure I do if I was to do a close reduction. And the important thing here, again, is to ensure that elbow extends. And back to what I was saying in terms of on extension, the anchoneal process hooks onto the back of the humerus, and that's what's going to maintain that stability. It's important to understand that with joint immobilization, we try not to immobilize the joint for an excessive amount of time. And as you probably all know, if you immobilize the joint, it does affect the cartilage health quite significantly. And if you stop the joint from moving, the cartilage starts becoming soft and then degenerate, and often you can get irreversible cartilage damage. And so one of the methods to circumvent that is to put dynamic X-fix stabilizers through the elbow. So this is one method that sometimes we do use. So after close reduction of the elbow, what we can do is actually place, so if you look on the top image on the right, we can place 2 pins across the elbow. So one through the distal humerus and then one through the olecranon. And initially you can put a linear X-fix, as you can see on the top right image, and that maintain extension as well as medial and lateral stability of that elbow. And then once the swelling goes down, you can take away the connecting bar, so the bar that stabilizes the pins, and then change it to the rubber bands, as you can see on the bottom image here. So you put rubber bands around the two pins, the two bilateral pins, and what that does is it continues to dynamically extend that elbow, but also allows the dog to have some degree of flexion. And so the idea behind that is it allows some degree of mobility through that joint and hopefully maintain some of that cartilage health. But mostly it allows an extension of the elbow and stability,
Alen,
maintaining stability. Yeah.
can I ask, with those X fixes with the hardware
Yeah.
in that location, do you see any problems with kind of rubbing on the body wall or bruising or discomfort?
Yeah. So I think absolutely yes, Anna. So I think in that location, rubbing on the body wall is probably not a major problem. So at that level, it's probably distal enough that it's away from the body wall. But I think the main issue with seeing an X-fix like that, especially when they're under quite a lot of load, is that you do get pin loosening over time. So as you get pin loosening, you can get irritation of the soft tissue as well as of the bone, and that can be quite painful for the dog. And often you get quite a significant amount of soft tissue discharge, irritation around that pin track. So you often get quite a lot of exudation out through the pin track as the pin exits the skin. So it does come with disadvantages, but there is a reason why we do put pins in for I guess other reasons as well. Does that answer your question?
Yeah, it does. That's good. And
yeah.
Paul's got another question. How long do you typically leave these on for?
Yeah, good question. So so it does depend on the stability of the structure, but tend to leave this in for about 4 weeks. Okay, but again, it does come down to whether you get quite a significant pin tract irritation, those kind of things. But I would usually recommend trying to keep this on for about 4 weeks. All right, so that's usually how I treat. In terms of, I just want to go through some of the studies regarding elbow luxation. So this is a paper from largely the UK. One of the Australian surgeons is on this paper, but this is by far the biggest collection of elbow luxation that is reported in the literature. Interesting, there's only 37 dogs, and it's not many dogs, but it's yet the largest study. So in this study, there's actually a combination of either treated with close reduction or treated with open surgical reduction. And there's a variety of different ways they reported to have stabilized and open surgical reduction. Quite a long-term outcome measure in this study. So 37 dogs over 7 years at 5 referral centre. So what we know is that elbow luxation is actually quite uncommon, quite an uncommon condition that we see. And so outcome for this paper is major complication was about 20%. And the most common complication that we see was re-luxation after close reduction. And so how they managed the close reduction was, one, they just push it back in, close reduction again, and then external coaptation. And then 3 were surgically stabilized, and then 1, unfortunately, was euthanized. So what's important to note here was that 4 out of 6 elbow luxation occurred in dogs with orthopedic injury involving other limbs. So I think one of the risk factors that we need to educate owners, especially if we see multi-trauma cases, is that if a dog has multiple limb trauma, the risk of complication does increase. And then the other complication is implant infection. Largely, this paper found that the majority of them have good outcome. So splitting between an open reduction or close reduction, about 90% of them actually do very well. This was based on a questionnaire results, but yet the majority of them reported to have pretty good outcomes. So that's usually what I recommend to the owners in terms of either open or close reduction. 90% of them do pretty well. The remaining 10%, I think, do have some degree of persistent lameness, but in the next paper, you will see that the majority of them still remain to function pretty well. So this is the other paper that report a fairly reasonable amount of traumatic elbow luxation. But this is the paper that looked at the largest amount of cats in the literature, 11. Again, not many, but it's the largest we've got to work with. In this paper, they attempted close reduction in all the animals. And so after reduction, 3 of them had quite severe instability, 3 of them had mild instability, and then all the other ones had adequate stability. After close reduction, what was interesting is that the 3 that had severe instability reluxated. And so I think that's when we do a close reduction, like I said, I always attempt a close reduction initially. And after reduction, I assess the instability. So back to how I assess the instability. So back to that Campbell's test that I spoke about earlier. So once I get the elbow reduced, I flex that elbow and then run it through the Campbell's test to see how much instability that I have. Whether the joint just luxates and pops out immediately. And if there is a significant or severe instability, meaning the pronation, supination is quite severe or it just pops out, then those are the cases that I recommend to the owners. We probably should be doing some further augmentation. So probably some sort of ligamental augmentation or prosthesis to stabilize this joint, because with severe stability, there is a much increased risk of reluxation. So outcome in this paper, 70% of them were excellent. 7% of them did pretty well, and then in this paper, 20% of them had a persistent lameness. So 10-20% persistent lameness after elbow luxation. What's interesting in this paper is that all cats did excellent after close reduction. So despite what we said in terms of with cats that in order for them to luxate, both medial and lateral collateral ligaments have to be ruptured. Despite that, all cats in this case studies, which is the largest amount of cats, all of them had close reduction and all of them did excellent. So I tend to recommend more aggressively in cats with close reduction. And even though they have significant instability, based on this relatively small numbers and from my experience, a lot of the cats actually do pretty well despite a severe instability. And I think it's largely to do with the body weight that may be causing them to have a relatively good outcome. So again, all cats underwent close reduction and they all did pretty well. So this paper suggests cats probably tolerate elbow luxation a little bit better than dogs.
Alan, I've just
Again, a fairly old paper, but this was an interesting paper that looked at clinical results after traumatic luxation. And the interesting part of this study was that 100%, so all dogs that had elbow luxation and reduction of the luxation, long-term, all of them developed DJD and OA. And so I always warn the owner that even though we can get the elbow back in, even though the dog may do pretty well, even though it may not come back out, unfortunately your dog is at risk of developing OA long term. And I think they need to understand that. And I suspect, and this paper suggests that the DJD is probably because of persistent instability or damage to articular cartilage at the time of luxation.
Alan?
Yeah.
Can I jump in with a question from Paul?
Yeah, of course.
What sort of imaging do you do prior to make your decision about sort of open or closed reduction?
Yeah, so I don't base my decision on imaging with decision of whether to do a closed or an open reduction. Again, I base my decision on the palpation, the degree of instability. I guess theoretically you can do advanced imaging such as MRI to look at your soft tissue injury or the degree of soft tissue injury. But I think the physical exam palpation is probably much more useful than any advanced imaging that I can provide for you. So I obviously do at least servo radiographs and do palpation to help me guide my clinical decision. Does that answer your question, Paul? Hopefully, yes.
Can I actually add to that now that you've got
me
in elbows? How often do you see concurrent fractures in the bones surrounding the elbow joints, which are notoriously difficult to see radiographically?
Yeah, great question. I think it's actually quite rare to see humeral condyle luxation. So humeral condyle fracture. So the most common distal or elbow fracture would be involving the humeral condyle. So either unicondylar fracture. So humerus. So very common for us to see with trauma distal humeral condyle there. But I think either one of them will give way. So either a luxation or the bone will fracture. And to answer your question, I rarely see a luxation with a fracture. The only thing that I sometimes do see is an ulnar fracture, concurrent with a luxation. So you can get something called a Montague fracture, where there is a fracture of the ulna or the radius, and then you get a luxation of the radial head. So that's a very specific fracture called Montague fracture. I won't go into that too far. You can Google that. But to answer your question, luxation, fairly rarely to see it concurrently. I think either one of them give way before the other.
Thanks.
Okay. So I've gone through traumatic elbow luxation. Hopefully that covers what we really need to know in that. I think I've covered how I treat it, how I diagnose it, and kind of how I what I think about it. So the next bit is I want to go through congenital elbow luxation. Again, this is a fairly rare disease that we see, but occasionally we see it, and it can be quite confusing as to how we treat these cases, because I think with congenital elbow luxation, which I'll go through in a sec, with congenital elbow luxation, one, it presents quite in a variable spectrum, and also no one really knows how best to treat these elbow luxation. So with regards to congenital elbow luxation, it comes in 3 types. So 1, 2, and 3. And so type 1 is where you see the radial head luxated, but ulna is still in a relatively normal location. So this is a radiohumeral congenital elbow luxation. So type 2 is where the radial head is still in place, but the ulna is luxated. And so this is purely a humeral ulnar disarticulation. And often what you see is that there is a lateral, so the actual ulna itself actually rotates laterally. So with a visual exam, when you actually palpate the dog's elbow, you can feel that there's a bony protuberance on the lateral side. In these cases, the radial head still remain in place. And then type 3 is where both the radius and ulna are luxated. And in terms of diagnosis, pretty easy diagnosis with radiographs, and you can see whether the radial head is luxated, whether the ulna is luxated. In terms of treatment option, like I said, it can be quite variable. I will go back actually one step. In terms of what we usually see clinically. So with a type 1 congenital elbow luxation, the clinical signs can be actually quite variable. Often, even though puppies can have a luxated radial head, you can get a very asymptomatic elbow or asymptomatic dog where you don't notice any significant lameness until maybe when they get a bit older. Whereas with a type 2, these are the dogs that actually are quite clinically affected. So these are the dogs that usually are quite lame from a very, very early age. Whereas type 3, they're always lame and they present as a very young patient. So a few treatment options, and like I said, no one really knows how to treat these. And no big long-term studies have been done looking at what's the best way of treating these. So type 1, again, like I said, there could be minimal lameness or impairment early in their life. And most owners may not notice until 3 to 5 months of age. And often what we find is that there is actually quite a poor correlation between the degree of deformity and the amount of lameness or elbow pain. Type 1, not always surgery. So even if we are presented with a dog with just a radial head subluxation, it's not always surgical intervention. So if a dog is very mildly affected, conservative treatment is absolutely acceptable. Patient should certainly be closely monitored until maturity. So this is where no one really knows how to treat it. So the thought is, if we want to treat and get that radial head back in place, delaying the treatment until skeletal maturity may be advantageous, because by doing surgery, we may cause iatrogenic damage to the growth plate and subsequently cause angular deformity from that. But if we were to delay the surgery to later, then because the articulate surface is not under load, there could be irreparable joint remodeling that even at a later age in adult, if we try to get that joint reduced, there could be quite severe damage to the articular surface. So if you were to be presented with a dog that are indeed quite sore, so clinically quite lame, and you don't think this dog can get through life with just medical management, then open reduction is certainly something that we can try. So usually we go through a lateral approach and then approach the proximal radius. And in order for us to get the radial head back in place, often we need to do an osteotomy through the top of the radius. So you can imagine with type 1, the radial head is luxated. And in order for it to get back in place, we do an osteotomy. I'm not sure how well this is showing, but we do an osteotomy through the radius. And then that allows that mobility of the proximal radius to get back into the articulation. And then after we get that radial head back into articulation, that's when we decide, what do we do? So we can either do a lateral collateral ligament and joint capsule repair and try to use the soft tissue to keep that in place. But if there's a difficulty and difficult to maintain that in place, then you can use a bone plate, get the pin, a transarticular pin to keep that radial head in place, or actually put a screw through the ulna up to the radial head and keep it that way. In terms of which way's best, we really don't know. But these are all the treatment options that have been reported. Interestingly, in 2015, someone actually treated one of these and just cut off the radial head and didn't even bother to get the radial head in place. And interestingly, this dog actually did pretty well, 11 months follow-up. Case report, but potentially worthwhile to consider. This is another way that people have tried fixing it. So as you can see in the middle image, you do an osteotomy and then you reduce that radial head back in place. And then in this case, they use an X-fix to keep the luxation in reduction. The other options, if it doesn't work, arthrodesis, amputation. So obviously they're the salvage options. Type 2. So again, like I said, these are the lateral rotation of the ulna. And these are the group of dogs that are severely affected. So even though, again, no long-term or large number studies have been published, these are the cases that if we see with the ulnar luxation, I do think these are the dogs that we really should be pushing for surgery, even though there could be variable outcome with these cases. If we don't fix these dogs, my opinion is that they will never use those legs properly. So I usually recommend some sort of reduction. So you can do a close reduction or open reduction, but afterwards you can place a transarticular pin from the ulna into the humerus to keep it in place. So that's just one way people have tried fixing with artificial ligaments, all those kind of things. No one knows what's the best option, but I think the take-home message is that with the type 2, with the ulnar luxation, these are the cases that I do believe benefit with surgery. Type 3, luxation of the radius ulna, and again, no published data, but because this is a combination of really a type 2 and a type 1 luxation, because the ulna is luxated, these are the cases that I do again feel are going to have benefit with some sort of surgical reduction and intervention. And these are difficult cases to treat. So, and often from experience, these cases can end up needing some degree of salvage salvage procedures such as an arthrodesis. And certainly these are the cases that I think benefit with referral treatment. That's it. That's me for the night.
Do you want to crack a beer or?
Yeah, I know, right? If we all crack a beer together.
Yeah, we do a big cheers.
Are there any questions, Anna?
Not from me. That was great.
Okay. Anyone from the group? No one?
No chat messages coming through yet.
Good.
So any questions? A big thank you from Helen.
Oh, thank you.
If anyone thinks of any questions after the fact, you can always email either me if you don't have Alan's email address, or alen.lai@northsidevetsspecialist.com.au, and he can fill you in. And I probably owe everybody an apology because I read elbow dysplasia, not elbow luxation, so I've advertised this wrongly. Sorry everyone, but I'm sure Alan will tell you all about elbow dysplasia if you're interested as well.
Yeah, certainly can. Maybe another time I can go through elbow dysplasia.
Okay.
Unfortunately, I think if I was to give a lecture on elbow dysplasia, it'd probably take 10 hours rather than 1 hour.
At my level, Alan.
Great.
All right, thank you so much, Alan. Thank you everybody for coming. Alan will be on again same time in 2 weeks' time, and we'll confirm obviously timing and stuff within the sort of 48 hours before and let you know topic. Our next rounds for Northside will be Mariano, who is on Wednesday morning, 9 a.m. And he's just sent out some cases, so I'll forward that to everybody with the Zoom link, but we'll see you 9 a.m. Wednesday. Helen, 9 a.m. Wednesday. Thanks everybody again. See you later.
Thank you.